press down, so almost like you're hooking. If anyone's a rock climber, I know some people are doing that. You'll hit that top anterior aspect of the tibial plateau.
Okay.
Does that make sense?
Yeah.
It's like just like a rock climber. Again, why you want the joint space open. So finding the condyle, slowly. Whenever I'm doing palpations, I think I've said this to you all at various times in various ways. I never pick my fingers up and move down because it's very easy to go too far. So always keeping contact with your fingers on your patient or your hand, kind of depending on whatever you're palpating. So that way you're not going too far and you're appreciating all of the various structures that you're going over. So from condyle, joint space, pushing in a little bit, and as I press down, I can feel that anterior superior aspect of the tibial plateau. Okay? What's next? Tibial condyles. So, still on that tibial plateau, as you're coming down, slightly medial and lateral, you're not going to go too far. The next bony ridge that you're going to feel on that anterior aspect of the tibia are the tibial medial and lateral condyles. And we'll ask if you guys happen to get, femoral condyle, epicondyle, whatever it is, we'll say medial or lateral. So it's just easy to palpate both at the same time when you're using two hands. Does that make sense? Yeah. So medial and lateral tibial condyles, just inferior to that anterior aspect of the tibial plateau that you're feeling. Okay? I'll do two more and then we'll practice a little bit. So in between your medial and lateral tibial condyles, or if you come down off the patella, you can find where the patellar tendon attaches, which is your
Tibial tuberosity.
Tibial tuberosity, and that one's very prominent. Not quite razor pointed edge, but definitely a much larger bump that, again, starting laterally and moving in, or starting from the patella and moving inferiorly, you're able to find. And you want to make sure you find the most superior aspect, most inferior aspect, medial and lateral edges of it, and you'll feel on the superior aspect that thick tibial, patellar tendon. And I'm talking to you, so sorry. That patellar tendon attaching to that tibial tuberosity. And then the last one we'll do before we practice is going laterally from that tibial tuberosity. You don't want to go too far back, because if you go too far back, you're going to run into what bone? Fibula. So not as posterior as your fibula, but as you're going back, you're going to feel another bony prominence. And this is where your IT band attaches, also known as
Gerdy's tubercle.
Good. The way that you can confirm that you're not on the fibula is you can move a little more posterior. And the fibula, you should be able to do AP, PA mode, so moving it, wiggling it back and forth, and then coming forward from there. Or you can also invert and evert the foot, and there should not be any bone movement. Your fibula will move with foot, ankle inversion, eversion. Your Gerdy's tubercle will not move.
What's the difference between the lateral tibial tuberosity and the Gerdy's tubercle?
That's a little, it's more medial superior. It's easier to see on a picture if you look at it.
So it's just tibial there's no lateral tibial tuberosity. That's what I heard you say.
Just Gerdy's tubercle. Condyle is what she was saying. Yeah. So that's more like superior medial to it, but it's easier to see on a picture. Gerdy's tubercle, and that's like a very subtle bony ridge, whereas Gerdy's tubercle is, there's, your IT band attaches there, so it's very pokey prominent, but not the fibular head.
Is this Gerdy's tubercle?
Maybe. That's it right here. Okay, questions about that? Let's practice those for a few minutes and then we'll come back and continue.